Well, thank you everyone for joining us today. I want to thank everyone for coming to our ONC Annual Meeting and specifically for joining us in this breakout session to talk about private and public sector updates related to prior authorization. My name is Dr. Thomas Mason. I'm the Chief Medical Officer of ONC. I've been working for some time now on our clinician burden reduction work. Many of you may not know that the 21st Century Cures Act calls for HHS to explore what are the burdens that are facing today's clinicians and how can we at HHS reduce regulatory and administrative burdens relating to the use of electronic health records. As a part of this, we partnered with CMS and went out on a tour of the nation and hosted a series of listening sessions and brought together a diverse group of stakeholders and asked, what are the main challenges that you're experiencing today with using electronic health records? What are the things that are missing? What are things that we can do to make the clinician workflow access for patients to their data? What are things that we should be thinking about to decrease the burden? One of the top burdens that we heard was related to prior authorization and the inefficiencies that come about from the existing prior authorization workflow. As a part of a 2018 American Medical Association survey of 1,000 physicians, they found that physician practices spend on average 15 hours per work week completing prior authorization requests. That same survey showed that 91% of physicians reported care delays associated with prior authorizations. And a more alarming data point from that survey showed that 28% reported that prior authorization has led to a serious adverse event for a patient in their care. And just a week ago, I was speaking to a physician colleague who was caring for an elderly woman that had just been released from the emergency department with a diagnosis of pulmonary embolism that was prescribed upon discharge an anticoagulant, oral anticoagulation medication. And he told me that he spent over 30 minutes on the phone trying to get this medication that was indicated for her, and just the struggle that went into and the amount of time that he spent on this one particular patient that really needed this medication. But just as an example, I hear from physician colleagues, from patients as well, in terms of showing up at the pharmacy and not knowing that there was an additional step required. We've been working on uncovering what are the barriers, what are the solutions. Clearly there are pockets where there are successes, but we also hear from the physicians that are really burdened and need to take advantage of some of the work that's ongoing in the healthcare sector to make this process more efficient, to improve automation within the electronic workflow, and to move towards an auto adjudication of these prior authorization requests and improve the communication and the transactions that occur between the provider and the payer. We have gathered today really an all-star team to talk to you today about what's happening. This panel is really focused on what are the successes, what work is ongoing to help improve the prior authorization workflow. I'll briefly mention each panelist, and the flow of this breakout session is each panelist will discuss for about 10 minutes or so and provide remarks on their particular area of focus, and then we'll open it up for question and answer and more of a discussion and dialogue. But first we'll have Jocelyn Keegan, who is a payer practice lead and Vinci program manager, and is also at Point of Care Partners. Following Jocelyn, we'll have Alex Muggy, the Deputy Chief Health Informatics Officer at CMS. Following Alex, Kate Berry, Senior Vice President at AHIP. And then Miranda Gill, Senior Director of Provider Services and Operations at Cover My Meds. So at this point, I will pass it over to Jocelyn to talk a little bit about the current landscape and the different workflows in terms of medical service prior authorization versus pharmacy or medication prior authorization, and talk a little bit about the standards and sort of where we are and some of the work underway to help better automate prior auth. So Jocelyn. Should I go back one?
Nope, that's perfect actually if we go forward one. So this is going to be a little like speed dating, and I'm going to beg forgiveness for the folks that are deep experts in any one of these particular domains. It's not often I have the opportunity to talk about both pharmacy and medical prior authorization at the same time. And there's been a tremendous, I would say, resurgence and interest and momentum around medical prior authorization in the last 2 years. And we've continued to make progress on the pharmacy side. So for just a grounding, I thought it would be good to explain really where the market is in reality today, and not in casting judgment or aspersions, but just sort of give people sort of a real perspective on what's happening and the progress. I've been involved with prior authorization since 2010 when I made a decision to move into healthcare IT from a different industry, and there's been a number of challenges for a multitude of reasons around getting the existing standards in place. So if we look at X12, really the home of HIPAA and the HIPAA transaction sets, there's the 270, 271, which is really the eligibility workhorse that really prepends every transaction that happens in the industry today. We have the 275 and 278, which tops out, I think, at about an 8 to 10% usage around prior authorization, depending on whose study or what year you're looking at. And primarily is used for a submit and then a update status, and a lot of the ancillary data is generally sent by fax or via other mechanisms to payers to be able to complete the prior authorization. On the NCPDP front, there's been a standard in place since the mid-2010s. That was actually produced as a draft standard and approved by the body that governs the pharmacy standards in the industry as the standard for use around pharmacy. So it's script EPA is the standard itself. And I'm going to caution the phrase universal. It is universally adopted in the sense of all of the e-prescribing applications. There's many providers, payers, and vendors in the space that use that standard, and it's being used widely. I'll leave it to Miranda to talk a little bit about some of the challenges in the industry about why that continues to be retrospectively done from the pharmacy as opposed to the provider actually doing that. And part of that is based on the existing use of how formulary benefit works at e-prescribing workflows today, and the challenges of having that data be as timely or as accurate as we need it to be. We'll also spend a little bit of time, I think, in the discussion today talking about the status of real-time benefit check. Many of the participants in the market have developed proprietary solutions around real-time benefit check, really trying to get it to patient-specific information at the right point in time in workflow so that a provider can actually have a conversation with a patient while they're in their care about what the cost of a drug is going to be, what the likelihood of what's going to be covered or not covered by their particular insurance is really critically important to be able to happen sort of bedside with a physician and a patient. And there's work underway both on actually the NCPDP side and then also for consumers on the HL7 side with really moving a standardized version of real-time benefit check live. HL7, I'm involved in Vinci, and we've done some significant work, and as I just mentioned, there's work around RTBC being done under Karen, the Karen Alliance. Really, I think, has the power to fill in gaps where we've struggled, I think, with some of the sort of larger transaction sets in the past. So CCDA continues to be a workhorse for accompanying things like X12 today for getting clinical data to payers from providers. And then I'll, in a couple slides, talk a little bit more specifically about what we've got underway from a Vinci perspective with support from a number of the EHRs, providers, and payers in the market to really work up front of prior authorization, where you need to get to the 278 standard to be able to really lessen and reduce burden on providers as we've discussed. I'm going to spend some time just talking about sort of the differences between prior authorization between pharmacy and medical. Like I said, I don't often sort of look at these in two pictures, so it's an interesting perspective. The point I wanted to get across with this slide is that, you know, the challenge around prior authorization, anyone that's spent time in a provider organization watching how they deal with PA, just from a day-to-day existence, is way beyond whether I need to submit a prior authorization and get it approved. It's really about upstream having access to the right information. So this is not by any means an extensive view of every step that needs to happen, but I wanted to show what actually happens between a provider deciding on a service, a surgery, a specialty medication, an infusion, a drug for one of their patients that's sitting in front of them, to all the steps that need to be gone through to be able to get to the point where the patient actually receives the service, is on medication, has gotten their infusion, has gotten their DME their DME actual artifact, or the home health service, right? What actually needs to happen. And today, with prior authorization on the pharmacy side, we do a good job of sort of solving a bulk of that, of those steps. You know, EPA really does a good job sort of upfront when the data quality is there, or when a provider organization does what I refer to as manual automation. They basically set up processes inside, they create cheat sheets to sort of back out of all of the complex formulary and benefit information for the payers in their state. That we do a good job of sort of automating or coming to near automation with prior authorization. And again, Miranda will be able to speak to this further about sort of stats and volume in the market. We see really good progress in sort of the submit, right, on the medical side, but that there are steps up front of really figuring out, and it's funny because I find in the market, this idea of just being able to tell somebody whether something needs to be prior auth or not seems really simple, and I think people pshaw that as sort of that doesn't really solve the problem. But if you're a provider sitting in an office in front of a patient, just being able to answer whether something requires prior auth, or being able to answer something about the patient's benefit while the patient's in front of you, is really game changing, even though it seems like it's not solving the same problem. And so my point here is that there's many gaps. There's ways to fill in those gaps by improving the amount of information that's available in clinical workflow to the teams that are actually supporting and caring for patients like us in the market. And I think that that's something I think we all need to keep in mind when we talk about how do we actually move forward and reduce burden, because it's bigger than just automation. So I'm going to take a minute to talk about what we're doing in Vinci today. There's a number of folks I can see in the audience that are actively participating and have been in working sessions or brainstorming sessions over the last 2 years, as we've really, I think, started to see that there are solutions out there in the market to be able to help us really get to this point of how can we get better transparency and clinical information about an individual's particular benefit in front of the provider. And so what we're doing with Vinci is essentially the project, for folks that aren't familiar, although I feel like all we've been talking about is Vinci this week, we're basically a group of stakeholders that have come together under the umbrella of HL7 to build FHIR-based implementation guides that are going through the standards process and are available for anybody to pick up and use in the market. And the calls are all open and you can get on and participate on them. And we've gotten really amazing cross-functional support from across the industry. And I like to describe it as there's a lot of active discussion that goes on on the calls about what we should or shouldn't do. But at the simple point, each of the boxes, the dark blue, orange, and light blue box represent an implementation guide. And to my earlier point on the last slide, the first implementation guide we built was CRD, coverage requirements. Just tell me about this patient's coverage. I just need to understand, do I need to do a prior auth, or do I not need to do a prior auth? Do I need to send the patient for an x-ray before I can move on to this imaging request? Just really basic information about patient-specific information. And then if I have to do something, tell me what the rules are. And I'd like to call out at this point in time, Alex Muggy and her predecessor, Melanie Combs-Dyer, actually funded this work out of CMS and MITRE. It's been an amazing gift for us as a project to be able to have their resources available to us. But documentation and templates is basically tell me what the rules are. Because if I know what the rules are, then maybe I can avoid having to do a prior auth altogether, because I know what's covered and what's not covered for this particular patient. And then if and when I actually need to do the prior authorization, then take the data that already exists. Don't make me rekey it into some sort of a portal someplace. How do we automate the work from that stage? And because HIPAA is the law of the land, how do I actually transform that information? So trading partners can take the data based in FHIR out of the EHR where it resides at rest, in its rest state, and actually transform it into the format that it needs to be in for X12 for the 275 and the 278. And then my trading partner can then send the data back to me, and so I can actually begin to get to the point that Tom was discussing, fully automating behind the scenes so that a provider or a patient doesn't even know that the prior authorization exercise is going. And there's a number of variations, but for today's purpose, I think that I'll stop there. And then we can revisit this this slide here, I think, in the discussion, because if I want to go back to the multi-step process. When we think about what it is that we as technologists and policy folks and implementers in the market need to do to really reduce provider burden around prior authorization, it's a much larger swath of activities than simply figuring out how to automate existing workflows. It's really about tackling each of these individual potential opportunities so that there's as little interaction, and when and if you need to do prior authorization, you do it as automated as possible. Thanks.
Hi, everyone. I'm Alex Muggy, and I want to talk to you a little bit about what CMS is doing in the prior authorization space. I'm going to be talking about this more from a policy perspective and kind of what some of the work that we're currently doing and how we're shaping our work for the future. So first I wanted to start by going over the Patients Over Paperwork initiative, which is an initiative in CMS that is focused on reducing burden. Tom kindly mentioned the burden reduction report that CMS worked on with ONC recently, where we went out and did a lot of listening sessions on the burdens associated with EHR use. And our Patients Over Paperwork team has participated in that and also done some additional work on sort of really digging down into the details of what are the burdens that clinicians face and how do we eliminate those to really increase patient time. So how do we increase the time that a doctor can actually spend with their patient, improving their clinical experience. So all of the prior authorization work that we've been doing really falls under this Patients Over Paperwork umbrella. So the Patients Over Paperwork team went out with the specific focus of learning more about the challenges associated with prior authorization. And we have conducted some significant outreach, including over 100 on-site engagements. We've also held various listening sessions and interviews and put out multiple RFIs. So we've got thousands of comments telling us what the challenges are with prior authorization, and now the team is taking that back to synthesize them and determine what are some of the ways that we can address those challenges. To give you an idea of some of the stakeholders that we've talked to, here's a list of the types of stakeholders that were included in this research and the programs that they represented. And I include this slide to really show you that whatever policies CMS decides to move forward with, or that we work with our partners to move forward with, we're really trying to make sure that we do that with a wide range of perspectives. So we want to hear from the patient, the clinician, the payer, all the stakeholders that are involved in the prior authorization process to make sure that we're taking a well-rounded approach. So two of the major pain points that we have heard about prior authorization are documentation requirements and prior authorization, the submission process itself. I included this quote up here for your enjoyment. So it says, "I hate to say it, but prior authorization is unseating electronic health records as the top source of burden for clinicians and providers." Just think about that for a moment. There's a lot packed into that statement, but really demonstrate just some of the pain points that we're aware of and things that we need to address for the future. So 2 notes before I go into the next few slides. Through our listening sessions, we are aware, CMS is aware, that electronic solutions are not the only solutions needed to address prior authorization. So while electronic solutions, such as the implementation guides and the standards that Jocelyn was just discussing and what I'll be talking about in the next couple of slides, we're focusing on the electronic aspect because we're at the ONC Annual Meeting, but we know that that those electronic solutions are not going to be a fix-all. They will, however, improve efficiency of the prior authorization process, streamline parts of it, But then there are going to be some non-electronic solutions that also need to be put into place to really address the full scope of issues. The other point that I wanted to make before going to the next couple slides is that I'm only talking about medical prior authorization here and won't be talking about prescription drugs, but CMS is doing significant work on the prescription drugs piece, and there are more widely adopted standards in that space. So we're not going to cover that here, but I would love to talk to any of you about it if you are interested. Sure. So first, the documentation requirements lookup service is a repository that CMS has built on a pilot basis. Jocelyn had mentioned that some of the challenges of prior authorization are really just knowing what the requirements are, just finding the requirements, and we've heard that that's one of the major pain points of prior authorization. And so this service is a repository that is API FHIR enabled, that will tell a provider at the point of care when they're in the office with the patient, does this patient have any prior authorization or documentation requirements, yes or no? So instead of the doctor needing to go out to a separate website to find these requirements, they can just ping this repository directly from their EHR and get a yes or no response. If the response is a yes, there are requirements, then they can say, then the system would say, what are those requirements? In fact, I have a slide that will show you in a more visual way right here. So the top set of arrows really is to show from the provider's EHR the question of, are there any documentation requirements? Yes or no? And the EHR interacts directly with the DRLS repository, and if the response is yes, then it goes back and says, what are the requirements, what are the templates, please send them, and it would ping the repository again, and those requirements would come right back. This is not prior authorization itself. It does not accomplish the act of prior authorization, but what it does is eliminate that step of digging through the websites and trying to find out, do I need to do anything for this? Or, eliminates maybe an unnecessary prior authorization submission where a doctor is reaching out trying to seek prior authorization or find out the requirements when really there aren't any. So this is to eliminate some of those steps. The next step in the process would be to move towards actual electronic prior authorization. And that's what I'm going to cover in these slides. And as a reminder, this is not for prescription drugs. This is just for medical prior auth. So the existing mechanisms in working with Medicare fee-for-service on submitting a prior authorization request include paper, fax, the Medicare, the MAC contractors portals, submitting a PDF, or using the X12278 standard. So these are existing standards that can be used, or existing methods that can be used for a provider to submit a prior authorization to CMS. What we are exploring for the future is moving towards a prior authorization submission that is more based on a FHIR-based API. It's important to point out that and Jocelyn did point this out in her slides previously, so thanks for teeing up so much to this story. This is great. There is an existing electronic prior auth standard that is the 278, which is listed under existing mechanisms, and because that is a HIPAA transaction standard, the 278 does remain in place with what we're exploring, but we are looking at ways to work with FHIR in combination with that 278 standard to streamline the process of electronic prior authorization and increase the adoption and use of electronic standards for prior authorization. I wanted to note that in the February 2019 NCVHS letter, NCVHS is the organization that makes recommendations to CMS about which standards should be adopted for the HIPAA transactions. And again, prior authorization is a HIPAA transaction, is one of the HIPAA transaction standards. In the February 2019 letter, NCVHS did recommend that HHS facilitate the testing of new standards, including FHIR. And so there's a quote up here just highlighting that this is something that we're all exploring and something that the DNR standards organizations have supported us testing and developing for future use. So how would all of this work? So looks very similar to the DRLS slide, but in this instance, from the provider's EHR, they actually have the template from the payer of what prior authorization data elements are needed. Some of those may be auto-populated by the EHR, yet to be determined, but then the provider would be able to, potentially need to do some manual work to fill out the template, but then the provider would be able to electronically submit this prior authorization directly to the payer and get a response. Could be, it would streamline this response process significantly. So to highlight again, we are looking at using a FHIR-based API for this transaction that would have a 278 extension to it. So it's actually called the Prior Authorization Support Implementation Guide. It's one of the Vinci projects that they're working through, and it's something that we're exploring for the future of CMS. And shows great promise and ways to use FHIR to really streamline some of that process and reduce some burden. Thank you.
So thank you. I'm Kate Berry with AHIP, and I'm really happy to be a part of this panel. I want to start by saying that, believe it or not, plans don't like prior authorization either. and we are painfully aware of the burden on providers, on doctors, on patients, and are highly motivated to improve the process. I can assure you of that. I also want to really applaud CMS and ONC for going deep on these issues and really listening to all of the various different perspectives of people. I think we all know there are opportunities to improve this process. We've had dialogue with the American Medical Association, the Medical Group Management Association, the American Hospital Association, Pharmacists Association, et cetera, and have really recognized the fact that prior authorization is an important tool for protecting patient safety and for promoting evidence-based care. All of that said, though, we know there are lots of opportunities for improvement. We have a number of major initiatives underway that sort of align with recommendations that came out of the consensus statement from almost exactly 2 years ago. We launched last fall an industry-wide survey to really understand the health plan perspective, the decision processes for designing prior auth programs. And I will mention that basically they are evidence-based, so plans really use both government guidelines, provider-developed guidelines, peer-reviewed studies to design their programs. They get provider input on the processes, and they regularly review all of the drugs and services that are subject to prior authorization and make updates based on new evidence, et cetera. They really do focus on measuring the impact and improving the process. So, in the survey results also, is it not close enough?
Project from the back.
Yeah. So in the study too, again, evidence-based, provider input, targeted services. So the services that are subject to prior authorization are typically things like specialty drugs, high-tech imaging, DME, genetic testing, those types of things. It's primary care, rarely subject to prior authorization, et cetera. I do also want to mention, I'd like to spend a few minutes on our Fast Path project, which is a demonstration project we just announced a couple of weeks ago. And this is a demonstration project looking at the automation of prior authorization process, or of the process, and looking at both use cases that both Jocelyn and Alex talked about. So both drugs, and prescription drugs, as well as medical surgical services. And we went through an RFP process to select 2 different vendors in these use cases. So on the prescription drug side, we're working with SureScripts, and on the medical surgical side, we're working with Availity. Really the goals of this project are to demonstrate the impact of automation solutions and using standards-based solutions that are scalable and that are as integrated as possible with provider workflow, and also are payer neutral, so they can work for providers regardless of what health insurance their patients may have. The 2 solutions that we picked I would describe as neutral gateways. So they enable connectivity between the health plans to deliver information through the gateway into, on the SureScript side for drugs, into the electronic health records that the providers are using. And on the medical surgical side with Availity, the process is delivered into a multi-payer portal that providers can access. So essentially, what we're looking at on the drug side is the real-time benefit check and the electronic prior authorization process. So the doctor will know when they're with the patient, does this drug require prior authorization or not? If it does, and there are clinically equivalent alternatives that do not require prior authorization, they can select another drug. If it does require prior authorization, they can submit the information to support the authorization right through the electronic health record, so it's sort of the real-time benefit check. And furthermore, they will have access to information on the patient's out-of-pocket cost, so it will basically reduce the surprise factor when the patient shows up in the pharmacy and doesn't know how much it's going to cost them. So we anticipate that will help with medication adherence as well. On the medical surgical side, similarly, when a doctor orders a procedure for a patient, they'll have the information right at their fingertips. Does this procedure require prior authorization, yes or no? If yes, they can submit the supporting information through the portal for feedback and determination from the plan. So again, enabling that information exchange, bidirectional, supported to streamline and reduce those phone calls and faxes. So we've already learned a lot in getting to this stage in the process in terms of the availability of different solutions in the marketplace, the status of adoption. But in this case, what we're really looking at is, what is the impact of automating aspects of the process on the provider office, on the patient, and we have contracted with RTI as our independent evaluator to really help us analyze that impact and produce a report, that will say, okay, hey, what's the impact in terms of time spent on the process, timeliness to care, the experience for the providers, et cetera, et cetera. And so we anticipate, running the project, starting, later this quarter, running it for about 6 months, and then RTI will do their analysis and produce a report that will share data on the impact as well as lessons learned, how to, to inform future implementation of these types of technologies so we can do a better job. Our hope is that this will, lead to more widespread use of these kinds of solutions and really, make a big difference in streamlining the process. So we don't plan to make any recommendations on a specific platform or solution. We recognize that there's lots of different solutions out there, but we are hoping to really learn a lot and show that this can make a difference.
All right, so I'm gonna talk a little bit, there we go. I'm gonna talk a little bit more from the healthcare provider side of this. I think the rest of the panel did a really nice job highlighting the standards, describing where we are today, and talking specifically about some ongoing projects. For me, in clinical practice, we know that there are about 300 million prescription drugs on an annual basis and that need a prior authorization. And about 37% of those fall through the cracks because the process is so cumbersome. So when we started, when Dr. Mason kicked us off today, he talked a lot about the impact on provider burden. And Jocelyn and Alex both hit nicely that while from a prescription medication prior authorization perspective, it is pretty widely adopted and there are utilized standards in place. When you look at PA volume in total, only about 46% of those prior authorizations are being submitted electronically. That does leave us with 54% that are still being done, what I like to call old school, manual, fax, and phone. And so what that does is it shows us that technology and automation helps, but it doesn't independently solve the problem of the administrative burden that we're up against today. So when we think about what are some of the potential impacts for making a bigger impact on burden, it really is about the network. It takes folks from all different walks of the healthcare ecosystem, those of us sitting up here on the panel, our colleagues in pharmacy, and also those in the pharmaceutical manufacturer space, to really be in tight coordination to eliminate prior authorizations where they're unnecessary and to improve the turnaround time of prior authorizations where they are necessary. So for me, as an emergency and oncology nurse, I had the opportunity to work on the Cover My Meds platform before I joined the company in 2017. So when I first started as a new graduate nurse, I quickly realized that the PA process was a barrier to my patients getting on therapy, and recognized that the time-intensive process kept me from doing clinical tasks to help move my patients along their journey. When I first started, the very first PA that I ever did took me about 50 minutes to do on the phone. Fast forward a couple of years into the integration from our academic medical center with a large EHR and Cover My Meds, submitting electronically took me about 20 minutes. So pretty significant difference. So 20 minutes when I'm submitting electronically, 45 to 50 minutes if I have to go back to that old fax and phone process. So in the industry, there are users, we heard in another session today, a number of users who have access and they live in their EHR, others that don't have a fully capable EHR. There are web portals out there that do help with the prescription drug prior authorization process, so outside of the EHR. But really, if we think about an ideal process, it will remain in workflow where the providers and their staff are already interacting with the patient and their data. So when you look at turnaround times for prior authorizations, we've made some progress by automating and leveraging EPA. We've improved turnaround time by about 13 days when you look at the difference between a retrospective and a prospective prior authorization. Jocelyn talked a little bit about that when we kicked off, and really where we want to be is we'd like to keep moving in that prospective direction. And what that means is leveraging tools like real-time benefit technology to indicate to the provider while they're in the office with the patient if a prior auth is needed. If there's a potentially therapeutic equivalent alternative, go ahead and switch to that. If they choose to move forward with the prior authorization, they can go ahead and start it right there. That's what we're aiming towards and keeping that prospective goal in mind. When you couple an RTBC, real-time prescription benefit tool, and an electronic prior authorization tool, you see about a 23% shift from retrospective to prospective volume. And what that does is it's giving the insights to the right people at the right time in the workflow to empower the patients. So I will be respectful of our time and make sure that we still have some time for questions. But I'd be remiss not to mention one other trend that we're seeing from the prescription medication prior authorization process. It's the idea of centralized prior authorization teams. This shouldn't come as a surprise to any of us who've practiced in healthcare. We've centralized and standardized a lot of things, billing, scheduling, with pretty great outcomes and savings in efficiencies and ultimately cost. So UC Davis actually published a pretty remarkable study on centralizing the prior authorization work. So here we are coupling the technology and the automation with some operational processes in the health system and with the EHR. The results are pretty outstanding. Centralized prior authorization teams have a 10% greater submission rate, indicating improvement in quality of the PA and efficiencies. They reduce the time between PA initiation and PA submission by about 22%. And ultimately, what's most important is they decrease the turnaround time by about 7 days so that the patient can actually get on the medication that they need to return to their wellness journey. So I think in summary, the technology and automation is helpful, and we have come a long way. I think we still have a little bit of a ways to go, but in order to truly be successful, it takes the entire network. It takes operationalizing some of these processes, and we're seeing the trends for large health systems and practice groups in moving to a centralized model, all keeping the patient at the center of their decision making.
Thanks, Miranda, and I just want to thank all of the panelists. It was really great to hear all of the work that you're doing, and if we could give them all a round of applause. And so now we do have just a couple minutes. I'm sure there have to be a few questions out there. There is a microphone, so please feel free to ask the first question.
Thanks. Joyce Frieden from MedPage Today. I have two quick questions for Ms. Muggy. I wondered if you could talk about where that Fast Path project is, like operationally, when we'll start to see something happen with that. And for Ms. Gill, can you elaborate a little on retrospective prior auth? I'm kind of unfamiliar with that.
Yeah, this is Kate. I'll talk about Fast
Oh,
Path.
Kate, I'm sorry.
Yeah,
I
no problem.
apologize. You're right.
So we expect to sort of go live in the next 60
I can't
days.
hear you.
It's not working, so here. We expect to go live with FastPath in about the next 60 to 90 days in terms of getting the providers activated on the functionality with the plans and the technologies we selected. The project will run for about 6 months, and then we expect to have the RTI report produced in about a year.
So, I'm sorry, are the providers a little select group, or is it a regional?
Well, so the plans that are participating represent about 60 million Americans. We've got 7 plans that are participating, both national plans and local and regional plans. And the providers are going to be selected based on both the providers that are affiliated with each of those plans and have access to the functionality of the vendors that we're working with. So it's sort of a combination. It will probably have, well, I don't know the numbers exactly yet.
Okay.
Thank you.
Yeah, so just to talk a little bit, I figured out none of our mics are actually on until we push the button. Good thing we figured that out at the end. Sorry. So retrospective and prospective PAs on the pharmacy side. A retrospective prior authorization can be pretty simply defined by one that is started at the pharmacy. Okay. So patient shows up, the claim is adjudicated, they started there. Prospective is where it started with the provider in the provider office.
Thank you.
Yeah, sure.
And I would just add to that, what we see in the real world is that because of sort of latency and quality issues with existing formulary and benefit, is providers make a decision to send to pharmacy, because pharmacy has what we refer to as like the golden ticket. They can do a test claim, and the test claim will fail for prior authorization. And so it basically saves the provider time. They might warn the patient to call before they go to the pharmacy, but essentially the maturity that's needed in emerging real-time benefit check is the thing that's gonna, I think, instill the trust with providers to know that they either need to do or not do, because there's nothing worse than putting wasteful work in front of a provider and having to do a prior auth they didn't have to do.
Hi, Mark Jacobs from the Delaware Health Information Network. We have been battling to try to help promote, solve some of the prior authorization issues in Delaware with our physicians. Real horror stories out there. we keep on digging down. I feel like prior authorizations, like if anybody saw Oak Island, you keep on digging the hole and hope you're gonna find treasure. You think it's down there, and we keep on moving the ball forward. From the prior authorization reporting legally, all health plans have to report to their data to DIN. And we basically have shown 75 to 80%, 80-some percent of all prior authorizations are approved the first shot. The others fall out into a number, and we could share these numbers. The others fall out into either denied and approved on first appeal, or subsequently there's a number that fall out because they may be experimental and things like that. We have tried collaboration tremendously with health plans, vendors, different organizations, and to no avail. We keep on being, we want to be able to solve some of these issues, and we feel we have the technology, the workflow, the buy-in, the physicians around that. And just a quick story. We recently started off with 3 health plans where we tried to get them to the table, and we worked with them. The first one dropped off because they contract out with a separate entity for prior authorization, and I don't want to get into names. But then we started down the path of a second one together, and they have been promoting the Vinci standards. Our platform supports that. We finally got down to a third because we're tied to them with Medicaid, and only to find out at the last minute, after getting the EHR vendors to support and modify the workflow in the orders work queue of the EHR and routing the prior authorization back through direct and supplementing the data within an HIE, to no avail, it stopped. It's very frustrating, and my point here is, if we're going to collaborate on this stuff, we need to have a collaboration. We can't have one solution that's out there by a particular partner that's out there, because the health plans there's a divide between the health plans and the providers. And we hear the stories constantly about the providers saying, things are stopping, I can't get this prior authorization approved. And then they're standing there in front of the patient that's saying, I need this MRI, and I can't get it. And then the squeaky wheel gets the most grease, especially with the provider picking up the phone and saying, I need this approved. All I'm saying is, let's collaborate together. Let's pick a number of different pilots we can make successful to prove this out and move the ball down, because as Dr. Rucker said, this is one of the last battlegrounds for improving it, and HIEs should be a part of this process. So,
thank you for your comment. I completely agree in terms of the importance of convening and collaborating across the many stakeholders to help develop solutions that are unique to a particular community and region. And Jocelyn, did you have a comment that you wanted to add? This will be the last question and comment.
So the only point I would make, and I've actually gotten to work with Mark in this sphere, is I think that this gets to the heart of what are the things that we can do to increase the transparency. And I think we're finally seeing movement with those upfront workflows. Some of the work that Kate's doing, I think, is headed towards that. For sure, the Cover My Meds folks have started to come and get involved, and some of their counterparts have started to get involved in the work that we're doing. I think it's about momentum and traction, but I echo, because I have somebody from ONC on one side of me and somebody from CMS on the other side of me, the need to fund pilots, and that takes hard work, because it's a little bit like North Korean talks, right? Peace talks, to be able to get all the parties to the table and to get people bought in with organizational priorities and operational staff to actually start this journey, not get it fixed, but start this journey to really adapt and adopt new solutions.
Yeah, especially in Delaware, where you have every single point of care willing to jump into the fray and solve this problem, and it stops dead when it comes to closing the loop with the health plans. And I'm not knocking health plans, because they have their own challenge with the medical policies and trying to work through this issue, but there's the deep hole, the Oak Island of sorts, where you get to a certain point and then you have to work with one intermediary or two intermediaries. So just general comments. Thank you.
Thank you. Thank you for your comment. And let's give the panelists one final round of applause. And thanks everyone for coming. We really appreciate the support.
Thanks, Tom.